All right, good morning, everybody. Welcome back to the Department of Medicine Grand Rounds. We have a great talk today, and I just wanted to, before we get started, just thank everyone again for coming in person, and thank you everyone on Zoom as well. But you know, it's great to be here in person, get to meet different individuals. So I encourage you all to come out next week. But for today, I'll hand it over to Dr. Timothy McBride in the Brown School, one of our economists, who's going to introduce our speaker today.
Thank you so much, Stephanie. And I got the great pleasure as co-director of the Center for Health Economics and Policy, along with the amazing Karen Joint-Maddox. We're so pleased to welcome here Professor Kosali Simon from Indiana University. She has a lot of different titles. I noticed she's the Herman Wells Endowed Professor. She's holds the Paul O'Neill Chair at the School of Public and Environmental Affairs, and she's a distinguished professor. And probably of note, she was in 2021 recently elected to the National Academy of Medicine. Part of the reason she's here is she is the president-elect of the American ASHECON, as we call it, the American Society of Health Economics. And we're going to be holding our conference here in June 2023, so mark that down. Abstracts due in about a month, so if you want to submit them. So Kosali is a nationally known health economist who specializes in economic analysis of health insurance and healthcare policy and health transparency, price transparency, which we'll be talking about today. She has numerous national leadership roles in the National Bureau of Economic Research and many other places. And I don't want to take time from her role to read all this, and she's editor of the Journal of Health Economics, co-editor of the Journal of Human Resources, and has had many honors. And so I think we will get a really interesting introduction to health costs and health transparency. So welcome, Kosali, and thank you for being here.
Thank you very much, Dr. McBride, and everybody for being here very early in the morning. And I know you have very busy lives helping patients. And so I am just delighted to get to have this conversation because it's about a topic that I think both economists, medical providers, and so many people who are vested in healthcare and health are just it really compromises everything we can do when we consider how high prices are and what price growth does. So I'm going to talk about drivers of healthcare and what price transparency laws can do to help us understand and address this problem. So I'm going to be focusing on a particular kind of law and particular data that the law relates to, but I will first be talking about what the broader topic of health transparency is and how it fits into many of the things we care about. So the law in particular that I will talk about is a law that went into effect in July of this year, and it's called the Health Plan Transparency Law. And so just to be clear what exactly this means, on July 1st of 2022, there was a vast amount of data released that was federally mandated by health insurers. And it was a policy to release this data that had bipartisan support, although it started with an executive order in 2019. I'll get to the roots of where this policy comes from, but essentially it's the negotiated rates by insurers and providers for all items and services for all plans. And what this means is it's a huge amount of information. There's also out-of-network prices. And the only part of this law that was postponed was prescription drug prices. So there were many newspaper articles that talked about the release of these data. It's really the biggest reform since the Affordable Care Act to the US healthcare system, the release of this data. And there's huge expectations of how this data release, this law going into effect, might address healthcare system issues. So I'm going to first talk about, where are we at this point in history in the US in healthcare costs and prices, and what have past policies done that have tried to address this issue. So the US has high healthcare prices. What this graph shows is what percent of the entire economy of the gross domestic product is devoted to healthcare expenditures. And it shows how that has been rising, but at different levels of growth. In the first decades that are shown here, it was extremely high, and then there were some periods of slowing down the rate of increase, and then there's been the hockey stick for the 2020. But if we look forward to what 2021 is anticipated to be, the government agency that keeps track of all this data within the Centers for Medicaid and Medicare, there is a group called the National Health Expenditure Accounts Group, and they put out a report in December of each year that talks about what it is for the previous year. They also have some midterm projections they put out. So in their midterm projection, they have said that when they release the finalized data next month for 2021, of course, it will show a reduction in the growth rate, but we are no doubt in an increasing fashion here. There has been no time really that we're meaningfully decreasing, but it's how flat can we get? How much can we reduce the growth rate? When we compare to other countries, no matter what the year we compare, if it's before the Affordable Care Act or after the Affordable Care Act, we have much higher prices, much higher costs, much higher total spending. And this is going to be one of the ways we think about, how do we think of how high our costs are to try and look at other industrialized nations, other wealthy industrialized nations, and say, what is it about how healthcare systems are set up? What are policies that could help us? This graph shows as a percent of income, because comparisons like these, which just talk about dollars of average prices, it's hard to know, is that reflecting just higher prices for everything? And so this kind of a comparison, which then says as a fraction of the country's gross domestic product, what is it like? We can see that for other countries as well, it has been increasing. And there was the 2020 increase for all countries, but our rates of increases are higher and our levels are much higher too. So why is that a concern? It's a concern, especially when put together with our health outcomes. So while the US is an outlier in everything related to costs and spending, people point to this graph as being one of the reasons we are really, really concerned about it. Although, of course, we know that many of the factors for health outcomes are outside of what healthcare spending could be addressing, and that healthcare spending could be especially high if other factors that contribute to these health outcomes are worse in some countries, right? So this is only to say that the US, when lined up this way, has worse health outcomes than other countries along these dimensions. So no surprises. I know there's such an expert audience on this, but I'm just putting this as background to thinking about what should policy do, what has policy done about healthcare costs. So before I go on, I wanted to first just talk about the concepts of price and spending, because already I have thrown out several concepts that are different. They're all part of our vocabulary when we talk about healthcare costs and spending and concerns, but there are different elements here. One is the actual transacted price per service. That is not necessarily the total that people might be concerned about. It might be concern especially about how much of that price is paid for out of pocket by a patient versus by the insurer or by the government. There's also often a concept of total cost, and there we have to consider how quantity is different. One of the reasons the US could be different in total spending is not just prices, but quantities that are used of healthcare. And then there's the focus on premiums, because often when it is privately paid, employers especially will point to premiums as being the thing that is the concern in thinking about how expensive is healthcare. And there too, there's the portion that's paid by the individual, the portion that's paid by the employer or by the government. And when it's the employer paying a portion, we know that's really coming out of what would have been part of a paycheck to an employee. With the government paying a portion of it, we know that's coming out of taxpayer dollars. So it's all shared, but people do care about what portions are coming out of different people's, at least immediate spending. Then there's the concept of affordability. And this was particularly discussed in the Affordable Care Act, which is how do we define healthcare affordability? And that's thinking about costs as a fraction of the income. And so the Affordable Care Act had a clause in it that said, if your healthcare costs are less than 9.5% of your income, that's somewhere in the law, a technical definition of affordability. So the price transparency laws that I am going to refer to are dealing with number one. Lots of other policies like the Affordable Care Act might be dealing with number four, or with and things we often track on graphs sometimes have to do with total price times quantity. So the price transparency laws are very specific to private health insurance. So I wanted to just put in context that even though Medicare and Medicaid are very important sources of health insurance, private health insurance is what covers the majority of this country. So this is for 2020 from the Census Bureau. Private health insurance, especially employer-based health insurance, is still the largest single coverage source. And so thinking about what the reimbursement rates are makes the private insurers even more important, because Medicare and Medicaid especially pay lower reimbursement rates. So thinking about how prices are set and why is it that there can be these different prices, we know that Medicare prices are administratively set. There are some adjustments for local cost of wages and so on, but they are set and are displayed very prominently and transparently. Anybody can go to the CMS website and see the prices that are posted. But for private insurance, it is very different. Private insurance rates are negotiated. They're negotiated on a one-on-one basis that is separately, each insurer, each provider, and there is often very explicit rules that information is very, very private and cannot be shared. And so the policy that went into place in July that required insurers to release all of the negotiated data for every single negotiation that took place is a huge, huge change from what has been the case before. I'm putting in italics here, if we can comprehend the files, because a big theme of my talk is going to be a story of how since July 1st, I have been, and many other economists and data scientists and data engineers, really trying hard to comprehend the files. And I will show a little bit of data analysis that we have been able to wrangle out, but it is really the story of a policy going into effect that hasn't yet, it's going to be hard to, there's a long road ahead still to see how this transparency is going to work out. So let's think about what are factors, why there may be different prices. Market power of the negotiators is one of those factors. The providers, the insurers, but also I'm not describing here the vast landscape of who's involved. There are insurance agents. There are, especially when we go to the pharmaceutical markets, there are lots of intermediaries in the distribution channels, pharmacy benefit managers, pharmacies, wholesalers, manufacturers. So there's just many, many layers of where market power is going to be involved in what the negotiations are. There's also now just a variety of what the contracting types might be. So there might be a separate rate if it's a fee for service. but there could be a value-based or capitation, bundled payments. So there's a variety of what could be negotiated. And we also know that prices will depend on other things like quality and reputation and how much you want to have a certain provider in your network for then being able to contract that network with an employer. So many things that matter here. So this 2022 policy action is not the first time that policymakers have tried to address costs, quality, affordability. So in the name itself, the Affordable Care Act was trying to address affordability, but it did it in a very different way. And when I'll show a slide, which, more this many years later, when we look at the Affordable Care Act, depending on whether you think it actually some features took place in 2010 itself, a lot of other features took place in 2014, but it's been a long time, and we have had many, many studies, and I'll talk about what appears the consensus out of what the Affordable Care Act has done, and conclude that it's on the coverage aspect rather than the affordability aspect that we have a lot more consensus on what the law has produced. So there were, though, in the 1,000+ pages of the Healthcare Act, many features that were aimed at affordability or costs. So I'll just talk about a few of them, but separate out how some of them were from the patient perspective. What's going to happen to the amount I pay in my premiums or when I go to receive care, or how comprehensive is my coverage? That's very different from thinking about affordability and costs from a government perspective as a payer for Medicare and Medicaid, and very different to ask ourselves, what does the Affordable Care Act provisions, what do they imply for private insurers? So from the patient perspective, there's quite a lot that was going to reduce and make sure that everybody's spending on healthcare would become below 9.5% of their income, and that government subsidies would help with Medicaid expansions, with marketplace subsidies. And there's even in Medicare, the donut hole being filled in. There are many features that reduced our out-of-pocket spending. For the government, there was the increase in spending, of course, from covering new people, but there were sources of additional tax revenue coming in. And specific to payment as in reimbursement, there was the use of alternative payment models, the setting up of CMMI to come up with innovative payment models, which, if they prove successful, would then be filtered down to the private payers, because we would expect to see insurers adopt these successful models. There were also lots of changes for hospitals in payment rates, for reducing readmissions. Medicare Advantage payment formularies were changed. Medicaid reimbursement rates were going to be increased for a number of years. But I want to make sure that we think about the way that private insurance was going to be affected was through these spillovers, because a very explicit role of the intention of the Affordable Care Act was not to disturb the employment-related health insurance market, because people were very afraid, is this going to mean that employers will leave their roles and ask for the government to be the source of coverage? And so things were designed with these firewalls about, oh, you can't go to the exchange if you have employer health insurance and so on. Part of the things that people are dealing with in policy right now about the family glitch, for example. But when we think about how we assess what the Affordable Care Act has done, it's very challenging to understand what the role has been in healthcare costs. So there are a number of studies that look at how payment models, how the ACOs, how shared savings programs are faring, and there's mixed evidence on those. But I'm going to describe a way that people take as let's think of just the simplest way to ask ourselves, has the Affordable Care Act changed healthcare costs? And that is to look at time periods of healthcare prices. So I'm going to point to this article by Melinda Bunting and John Graves in Health Affairs, and I'll zero in on the graph that is the key one here. And that is to say, we know what growth in per capita expenditure from the previous year has been. So earlier, when I showed you the first graph that was increasing the whole time, that was healthcare spending as a percentage of GDP. Now this is year-to-year growth rates in healthcare. It's all in the positive numbers, but there have been some slowdowns. And so in the year the Affordable Care Act is passed, the 2010 number, let me try and use this feature here, see if this works. Right here, sorry, right there, 2010, you can see that the decrease that then stayed throughout this time period started a bit before. So there is this debate about what of the changes can be attributed to the Affordable Care Act versus what of it is for other reasons. And so there's a huge amount of attention that is going into trying to disentangle this, but the state of knowledge right now is that it is certainly, it's that cost growth appears to have settled into a new normal, slower growth rate after the Affordable Care Act, but we don't know causally what parts might be part of the Affordable Care. But one thing that there is no disagreement on is that we have created lots of avenues for new forms of health insurance, and people have signed up for them. They have been implemented, and we are now at an all-time low in uninsurance. We have only about 8% uninsured. And this is clearly, even the time series shows that, but this is just, if you look at the accounting of what forms of insurance people have, it's from new avenues that were created that we have been able to reduce the number of people who are uninsured. So I'm going to go into now the cost side, but I want to, and I'll have this bullet point later, we really are in a different place in US healthcare today than we were when we were thinking about the Affordable Care Act, which is that we have largely solved the uninsurance problem. What we have are other problems related to costs. We have health equity and healthcare quality, health outcomes, and affordability as the biggest issues. Whereas for a long time, the nation was really grappling with uninsurance as the problem. So it is a different phase we're in. So I'll talk about what are factors that might be responsible for high costs and what are the consequences of these costs. So health behaviors, social determinants, there's lots of evidence on these being high challenges for why costs are high. I alluded to consolidation in healthcare markets. I'll show a little bit more of the details here because it's consolidation within the sectors, but also across the sector. So if you think about the healthcare landscape, there's all sorts of tiers. We can think about healthcare provision, medical insurance, there is pharmacies, manufacturers, pharmaceutical benefit managers. And so there's also consolidation vertically as well as horizontally. And this is a way of thinking about pharmacy benefit managers. These are the companies that negotiate insurance formularies for employers and insurers, and also with pharmaceutical manufacturers for rebates and with pharmacies. The big ones that are listed here, OptumRx, CVS, Caremark, and so on, are also consolidated with health insurance companies, with pharmaceutical, with pharmacy and healthcare providers through, for example, Minute Clinic. So this is a very different picture than thinking about each of these entities as being separate, and I'll talk about competition and information in that, right? So that was across some of these dimensions. Think about hospitals. There's also been high levels of consolidation, and that these have been increasing in trend. This slide shows from 2005 to 2017, the number of hospitals that are in a health system versus independent. And when we look at physician practices, we also see similar consolidation, that depending on specialty, there has been this increase, so that, for example, oncology is at 50% of practices being owned by a hospital or health system by 2017. And these are, again, these data are not always easy to obtain on this, but so this is a publication from 2018. Insurance companies are also, insurance markets are very consolidated. There's a way to, some of these markets we think about at a national level, and others we think about at a local level. So insurance companies and hospitals and physician practices, we tend to want to think about at a local level, whereas drug manufacturers, for example, we think about at an international or national level. In insurance companies, the market that usually is used as what's the relevant market to think about concentration is a sub-state area, so an MSA, metropolitan statistical area. And if we look at it this way, this is from an AMA report that is done every year, and the one for this year was done this current week, and so it has data through 2021 in it, that there is a way of defining whether a market is highly concentrated, uses market shares of insurers and calculates what's called a HHI index, Herfindahl-Hirschman index. And the Federal Trade Commission generally tends to call a market that has a certain number for that index, 2,500 or above, as being highly concentrated. And so according to that measure, 75% of MSAs in the US are highly concentrated. That means have fair amount of concerning monopoly power. And so that's what matters, even though when we look just across the nation as a whole, market shares don't reflect all of that concentration because some insurers are more dominant in some areas than others. So consolidation is a very important concern for healthcare costs, but so are all these other ones that have been noted in the research: administrative costs and rising insurance coverage rates, because the more that we insure a population, the more of the healthcare services we are ensuring people receive, we do have this consequence that it is going to increase spending and costs. We also have a lot of medical innovation, and these are both things, insurance coverage and medical innovation, that we don't want to discourage. Those are things we consider very important. We just have to also acknowledge them in the reasons for healthcare costs increasing column. But with all of these going on, which maybe these are balances we're making, trade-offs we're making, we, in that context, think about what is the role of price transparency? What's the role of competition and price transparency? So I'm going to talk about this concept now with regard to other markets, and think about another market, which we don't often compare with healthcare, but I want to draw some comparisons, and that is to think about airline travel. Okay. So imagine that the way we paid for airline travel is like health insurance, in the sense that our employer policy covered us for it, and that it had a 20/80 breakdown. So it was a cost share of 20%, and that we undertake the travel that we need, but we don't know the price in advance. We just go to the airport and we hop on the plane we need to. And afterwards, many weeks later, we get a bill and we are charged 20% of it, and the employer has to pay 80% of it. This is a market, of course, we know we are very far from that in airline travel. There's transparency through many online portals we can go to and price compare and decide which flights we're going on. And there's quite a degree of uniformity also. So healthcare is not what we want to compare to, because even in airlines, yes, there's first class, business class, and so on, but there isn't as much of the nuances of complications or modifier billing codes or complexities, of course. But it is sort of intriguing to think about how price transparency might make a market that is consolidated and concentrated have not as much of a concern about competition. In airlines, we think even though airline markets are very concentrated too, we are not as concerned because of the ability to be able to see the prices and say, oh, you got a fare that's $20 higher? Well, I know, I'm gonna make sure I, stay away from that. And then the pricing incentive is very different than when you think about what happens before July 2022, is that you would have a price that nobody would, realistically know about. So airline markets are very concentrated, as we know, with American Airlines having about 20% of the national market. And again, if we go into regional markets, then we'd see even larger because, you're not choosing nationally, you're choosing from the hub you're flying from to the location you're going from. And so on that route, there may be a lot more concentration. But we don't worry about it in that same degree because of the price transparency tools that are there. So that's the aspiration that led to these laws. But I'm going to go into the implementation difficulties. But we do know that prices are extremely important for patient welfare for many, many reasons, for financial health, but also because there's a lot of evidence emerging in this new literature I'm going to mention. We've got lots of them pointing to this Quarterly Journal of Economics paper about how price responsive people are. But that's about price responsiveness. A newer literature has started to connect the consequences of the care you missed because of high costs to, for example, mortality. So in this paper by Amitabh Chandra and colleagues, what they did is use Medicare Part D data that gave them almost like a natural experiment, almost like a clinical trial. Some people got higher costs and some people didn't, because if you turned 65 in January versus if you turn 65 in November, you had a different amount of time to get to the donut hole, to get to your cost sharing. So what they do is use that as, here's almost experimentally, I gave some people higher costs and some people lower costs, and now I observe how much care choices were affected. And they link then to how does that affect your health outcomes, and are able to show this very high gap in mortality. And so I think these are the pointing to number one, challenges that high costs are having on individuals' choices. But then you might say, well, the solution is just cover everything at zero cost. But then you worry, what does that send as upstream incentives to have prices set very high by companies and all of the different levels. So it's a very difficult fine tuning to do, to introduce cost sharing, to keep prices down, but to do it in a way that introduces it in different markets. So just want to also see if there are any questions. I thought I would put these as takeaways before I go into now talking about the data on price transparency. So price is very high, cost growth, we don't know what really works. We're not in an uninsurance problem anymore in the healthcare, in US healthcare. It's about equity, quality, and costs. And costs compromise what we can do on equity and quality. Concentration means that we are turning more towards price transparency as ways to solve problems. And even aside from the July 2022 law that I'll talk about, there are many federal policies that are pointing towards price transparency. So the price transparency and cost being the problem. Inflation Reduction Act and prescription drug pricing in Medicare. No Surprises Act which went into effect in January, which basically says that if you have a surprise out-of-network bill, it will be arbitrated in a certain way that puts caps on. And then more recently, perhaps the Federal Trade Commission has announced an investigation of pharmaceutical benefit managers to increase transparency. So with all of those as the background, this particular law, transparency and coverage, TIC, I'll use as an abbreviation, started with an executive order in 2019 that what it aims to say is want to increase ability of patients to choose healthcare that's best for them by making informed decisions about prices. Patients must know the price and quality of services, just like we do for airline traffic and many other things. So the requirement was that by July 1st, 2022, insurers post all the prices. Penalties for non-compliance is very high. Insurers did post these data sets, but they are extremely complex. They have been very challenging. I think we knew going into July 1st, many healthcare analysts were watching, waiting that holiday weekend. We started downloading the files. We expected that they would be complex, but we just had no idea how complex they are being. Still to this day, we are trying to. So I'm going to talk about what these laws look like. And first, I'll just show a little bit of what the rollout of this policy was. So in 2021, January, the first provision took place, which was hospitals were required to post their data, but very few hospitals did. The compliance was very low, partly because the fines for non-compliance was low. So lots of papers have been written saying, man, there wasn't much compliance and there's not much we can do with that data. But the 2022 law had high fines and insurers did post those fines. So high compliance. And it is planned in the law that by January of next year, there will be these tools where somebody can log in, put their personalized information and get a personalized quote. We do not know how that is going to roll out, but all these things come from this particular executive order, and then lots of details on rulemaking, because a lot in the executive order and in the legislation that then resulted said details to be worked out. And so I'm going to give a few snapshots of what the policy documents look like and where the complexity comes in. So this is what the US code looks like, where this section was put in. And this is what the Code of Federal Regulations, the rulemaking documents, said about, here, requirements for these files. So the creators of these files had to follow certain rules, and I'm not expecting, this is all tiny font, but just to say there are certain requirements that were put in, which made the files really complicated. So basically, a price has to be listed for every single provider, for every single plan, for every single insurer. And every employer is a different plan. Every employer may have 10 different plan options. And there may be 10 different ways through which payment may be done, and there's modifiers and notes and quantity discounts and all of these things, and the ways in which providers are listed. Some you could list the NPI, you could list the tax ID, you could list only part of the providers, and so completeness and what these files mean is just very challenging. In prior literature in economics, price transparency has shown to, for example, in the concrete market, there's studies on all kinds of markets, bring prices down, bring price dispersion down in most of the cases. But there are also some cases in which prices go up. So think about the negotiations. Again, if there is market power, if I am told my prices are now going to be public, think about the prices I'm going to quote. So there is a possible reverse loop here by which prices increase. So it's extremely important for us to go and actually test this is what's happening in this case, but getting the data is hard. I'm going to just go through quickly some of these slides and say, in the past, there have been some data sources that have been used, but they generally can't identify individuals. So there is The Healthcare Cost Institute has data from a certain number of insurers, but when the reports are produced, it cannot be identified, and so you can't link it to other data. They're not publicly available, and there's usually a long lag of when you can get access to the data, 2 years or so. But there are many things we know. We know that prices are dispersed. We know there isn't one price, and just skimming through a few studies that have done these looks at these data. So we know that there's also much higher growth rate in hospital prices versus physician prices over time. So that has been a finding that has been in multiple takes on the limited data that is available. So I'm going to now talk about what's in these files, the TIC files. So as I mentioned, before July 1st, we did know something about what the structure of the files would be like, because CMS had been holding webinars for the product creators in insurance companies to get ready these files. And so we knew there were going to be, there's a requirement on the format. It could be a CSV file or a JSON file, for example. And there had to be certain fields you had to put that information into. So we knew that going in. Some of these are required fields, some of these are optional, and some of them you got to choose where you put the information. But there are these requirements. But what we didn't know until the date that the policy went into effect is where to even find them. So we spent probably a good week just having a large team of us, many data science students. All this is a work of many, many people, just going and Googling and finding, even when you go to an insurer's website to find out where these files were, took data science master students and experts a long time to find. And remember, we're looking for every employer. There's going to be a separate file for every plan choice for every insurer. So that took quite a long time. The second was, even when we found them, to be able to download them. These are files that are, some insurers would have 1 terabyte of a JSON formatted file that was compressed. Even with the supercomputers at our university, we can't really and also when we start to download them, they time out on us. They block us often because they can see the same IP is trying to download the file. So there were lots of challenges there. Then after downloading, to open the file was also challenging because the RAM of our supercomputers even couldn't handle opening up, it really is. Once they're opened, then you have to, most of the files are in JSON format, which means they're in arrays and need to be parsed. You can't just open it up. And that also is a very big challenge. So I'm going to tell you about some of the files we were able to open, and then also a subscription service that has, there are intermediaries that are commercial entities that are saving and making these files available. And Indiana University has worked, as a subscription to one of these, and so do many other places, and talk about what we have gotten out of this. So we have limited our analysis to just a few billing codes to make things manageable, but really, even to make it manageable, first you have to open these files and then get them, right? But we have some ways. So Humana is an insurer that put their files out in not JSON format, but CSV format, and chopped them up into lots of little size files so we could open them instead of this one big one. So, but we have to go in, and find, we have to know what employer we're looking for, and we have to know that employer's EIN number, not just the name. And so we came up with a list of employers. We saved the files and then said, okay, we're going to get a list of employers in Indiana. We go to a public source. The tax IDs of some of these employers are publicly reported, so we can collect those, and then we go and look for the files. So these are some screenshots of how we go there. We find the place where the files are. We click on the thing that then opens up, and there are something like 228,000 web pages we have to scroll through. So the data science students look at the developer site of that and get the file locations. And then we get this sample. So I'm going to show you what we get as data from one tiny amount of this, which is for that 15-minute doctor visit billing code for just the fee-for-service rate, not the bundled, for just Indiana for employers that were in Humana that could be identified through these public sources. And so this is a snapshot showing the median negotiated price for that 15-minute visit 99213 billing code. And what I've highlighted there is Bloomington, Indiana, my zip code. And one of the things we see is that the median doesn't vary that much. When we then change it to 95th percentile, 25th percentile, we do see variation. And what we have done next is now get the NPIs linked to provider characteristics from the National Provider Index files and look at what determines variation. So there's a lot that it's not all ready to present, but I'll tell you one of the findings we have is we can look at who is an independent versus networked, and the rates are lower for those who are independent, for example. So lots of other characteristics we are trying to bring in, like ratings or experience. When we look at the institutional fees, there we see more variation. There are also fewer that are listed, of course, as institutional, but there's more variation there. So these other insurers, we've opened up some files from most of the large insurers. When we go to United, we have a big challenge here. United, like all the other insurers, have these very large files that we can't even open. But then one of our master students in data science said, oh, I think we can do the following, and then showed this trick how we can go in and even for a JSON zipped file, gzip has a utility that allows us to go and get in a little bit of data. So for example, it takes even to just go to the United site that lists the file. You have to wait 5 minutes for the whole page to load because there are so many files. And then we go and we click on one, and then we see inside this code is a link to where the file is. This is the file that's the 0.5 terabyte zipped file. But then we can, open it up in a little way and start to get this data. And so we've got a little bit of data like that from every insurer. I'm also going to say we also have through Turquoise, which is a company that it's a data science company that works in this area. We have extracted data for a large number of insurers, but there is a challenge. The providers aren't linked yet in that data. So we're not at that point yet. And so we can't show this so much, but just as an example, we've got distributions across all of the different insurers for these payment rates we can look at. So, we are not at the point that we can draw too many takeaways, but I hope the message I'm conveying and love to get any discussion on is that it's very hard to solve this issue of price transparency. And it's going to be a long road before we're able to use what the policymakers have intended. So we've lots of things to plan in the future.
Thank you.
Thank you so much. Do we have questions?
Oh, sorry.
Oh, are you?
Oh, good.
You should come up here.
I'll just check the chat.
Thanks.
Hi, thank you so much. That was a really amazing presentation. I had a question spot for request for opinion on the utility of a law that seeks price transparency, hopefully for the benefit of patients. But has rulings that say the files must be machine readable, not human readable. And the files are so difficult to assess that public universities with massive public/tax funded budgets have difficulty parsing through this data, such that you need commercial intermediaries to parse through the data. And I'm thinking like you basically need supercomputer AI to read this. So you get a society in which only AI and supercomputers, which I read as only it would be funded by large commercial organizations with their own biases. And read through this data. How far do we get from a human-centered law where humans are supposed to be benefit? I remember like Wolf's Travels being very much the big giants have a law that only laws with a number of words less than the number of letters in the alphabet can be passed. So everybody. So I guess I just wanted your opinion on this situation.
I think the concern is that even we don't yet see these tools, even if it's going to be through commercial sites that will get these, it's just going to be very challenging for us to then be able to vet, or let's say academics want to weigh in on, is this information being presented in the best way for patients to make decisions? It's going to be very challenging for us to independently assess, or just to know how long will it take before it's very accessible to researchers. So I can see the reasoning why, you know, our data that's being put out in society in all sorts of ways is just so complex that even large public universities are having a hard time keeping up.
Sure.
I'm not so certain that consumers are the audience for this, right? They can't make decisions at the time of crisis. They don't use the data currently. They don't use it right. And I don't think I know Jordan that because use it either. But it seems like maybe the employers are, right? So is this how Amazon should fix healthcare? Like just someone who has market power on the employer side using these data and use it, like how is this going to change?
I totally agree. I think even though the policymaker language is directed at the consumer, it's really hard to imagine that that's the way I'm going to benefit as a patient. It is through some intermediary, employers, insurers. Transparency at those levels should filter down to lower prices for me. So I think large employers are currently playing a big role in this. There are some sites that are being set up by large employers. So that's definitely another sector to watch that will.
Mark?
Can you comment? I think sort of fascinating about the presentation, and thank you, Mark. Is this alignment that's now occurring where you have for-profit insurers, for-profit pharmacy benefit managers, for-profit pharmacies beginning control patient, or excuse me, for-profit primary care providers all linked together, but attempting to basically capture patients and deliver care. And all of them, I would assume, have some kind of significant incentive to retain administrative costs in healthcare for their profit. And where is this heading? So, I mean, obviously it's popular. We're seeing multiple different companies doing this. Obviously CVS, Walgreens, but others too.
I think this is what regulators are going to be grappling with, is how do you balance, on the one hand, the need for companies to consolidate and pool resources in order to better manage and keep costs lower, versus the market power and pricing power that comes along with having large consolidation. I think this is just has been constantly a challenge, even in hospital mergers, of hospitals explaining, if we aren't able to merge, there's going to be lots of consequences. We're going to have to close doors and so on, versus the market power it creates. I don't have a good answer except to say it's challenging.
Tim?
So if I could riff off Kieran's question, and all of them, great job, closely. I think it's correct that, the law is intended to help patients and people. Maybe you could address this, because we know in economics, there's the principal agent model, as we talked about. And so even if the laws and we know that information asymmetry is a big problem. But the way we solve it is there's an agent out there who actually can operate in the interest of the principals. And in this case, the way you're describing it, I think would be the employers.
Employers.
Would be an example And maybe we can get to a place, I know the data stories are amazing, but if we could get to a place where employers could be the really good agents operating for the patients, for their insured, maybe that would actually get us where we want to be.
Yeah, I think that's where we'd like, it seems like that things would be headed. Employers currently don't even have the facilities of large universities in computing, so it's going to be through intermediaries of some type.
Thank you. That was a great talk. So laws as originally written are not always perfect or functional. So what do you think it would take to change the law to either focus on the most important data as opposed to all of the data, or standardizing the way the data is collected and presented so that it's more usable? Because you know what you presented is really kind of a nightmare, but some of that could have been deliberate, right? So it created the opportunity for obfuscation. But also, even if you were trying to do the right thing without guidance for how the data should be presented, because it's so complicated, people, even if their heart was in the right place, could present it in all sorts of difficult ways that wouldn't facilitate actual analysis.
I think that employers, I think waiting to see how are employers going to react. Are employers going to say, this information, which is so important for us to get to our patients, workers, is hard for us to currently use, and then pressure for something else? Or will it turn out that employers are finding some intermediaries that work and will be happy? I think it's too early to tell, but that's where the pressure could, if it turns out to be a problem, come from.
Any other questions? Thank you very much.
Thank you all very much.
That's a great talk. Thank you.